Good morning, everyone. Can you hear me all right there? Is that good? Now then, we've got a range of professionals in the room, different experiences, different units, and I want you to keep that knowledge in your heads as I ask this question. I want you to seriously imagine, take yourselves into this situation where you have angina, you've had your angiogram, and you found out that you need coronary bypass grafts. Okay, so I just want you to think about the impact, because it's very easy to be glib and think like a doctor and it's a patient having it, but think about yourself having it. And we're a slim, active bunch in this room, so that makes us a bit different to the normal patients that we have. But I suspect that we've all seen the different operations, and you might have seen the different complications of the operations, and I would say that the bilateral mammary approach in some centres and in some hands has more complications. And if we see them in outpatients, we see younger men and women who've had bilateral mammaries who can't get back to work, can't get back to their hobbies because of the hyperesthesia on their chest or because of persistent infection and sinuses, and their life's on hold. So it's a very, very difficult decision to weigh up. But you're a patient, you're with a keen surgeon, and I want you to think, which operation would you want? Mammary plus 2 bits of vein, or bilateral mammary artery graft? So just think about that. Think what you're going to do, and I'll ask for a show of hands just shortly, okay? So have you all made your mind up? Okay, who would have bilateral mammary grafts? Thank you very much, okay? And we'll see how that changes when we see the poll. I've got another question for you. I want you all now to imagine that you've decided you want bilateral mammary artery grafts. You've all decided you want arterial grafts. Just imagine now, would you go to a surgeon who does it occasionally, or would you go to a surgeon and a surgeon team who do it regularly? So I'm going to ask the question, who would go to a surgeon who does it regularly with a regular team? Okay, thank you very much. Right, I'll start my talk now. I'm looking forward to debating this with Bala. He is a keen arterial surgeon at Stoke, as you know. And what I wanted to put it into the context of surgery evolves and practice evolves, and we're all seeing changes on a year-to-year basis. But just take you back a bit further. Back in the 70s and 80s, when cardiopulmonary bypass was becoming safer, that this new operation was being brought in, there were young men, mainly in their 50s, women as well, dying of heart attacks. And suddenly there was this new procedure to prevent heart attacks, to save people, to cure angina. And it must have been, I use the term gold rush for good reasons. For surgeons and surgical teams, there was a gold rush on doing bypass surgery. And they wanted to do the operation quite quickly because bypass was a bit unsafe. Protecting the heart during the operation was unsafe, and so as surgeons and surgical teams, we were trying to do it quickly, and the vein was easy, the vein came out quickly, we did the operation quickly, and that was the standard operation in the 70s and 80s. Then Floyd Loop produces a paper, and who on earth thought of pulling the mammary artery off the back of the sternum? It's still the most difficult part of the operation. And yet, for some reason, that team decided it was a good idea to use this artery and put it on the front of the heart. And their landmark paper showed outstanding patency rates. And of course, we all know it was a flawed paper because the vein grafts to the LAD had great patency rates as well, but that was irrelevant. And what was extraordinary was, with a flawed paper, the cardiac surgical community in the world adopted the left internal mammary artery, and we were all using it, and we all knew it was good, and we were doing the right thing. But we wanted to get better. And therefore, if one arterial graft is good, we thought it must be better if you use 2. And that's why we're here today, because we're still debating it 20 years on, 25 years on, whether arterial grafts are better than the left internal mammary plus vein grafts. In my training, I saw the enthusiasts using bilateral mammary arteries. And you get scarred by the patients with the sternal wound infections. There's a registrar rewiring infected sternums. There was a new wing at Papworth, and this poor patient had persistent infection after bilateral mammary, and the poor patient exsanguinated on the ward, and it happened to be in room 13. So room 13 was taken out, and it was 12A and 12B after that. And then as a consultant, you regularly see new colleagues come in, and they are really enthusiastic about the science and the evidence, and they want to put their mark on the unit and make the difference for patients. And they come in and they do bilateral mammary grafts, and then suddenly you have a special clinic for the sternal infections, and it begins to weigh the unit down. So you get a skewed perspective of the outcome because you're seeing these infected sternums. And then, of course, you have the patients where the wound heals up all right, but they have incredible hyperesthesia, and they're on analgesics, and they feel tired, and they're not playing golf, etc., etc. And you just start to change your views about whether bilateral mammary arteries are a good idea or not. In Middlesbrough, we have like a lot of the provincial units, our population is quite static. People sort of don't move into the area particularly unless they're from the area, and people from the area stay there. And so we, in late 2008, we published our 1994 to 1996 outcomes for coronary bypass surgery. And it was basically mammary plus 2. I'm a bit appalled because when you look at the 1,100 patients that we reviewed in that era, the 30-day mortality was 3.3%. So if you think that was about 50 people who died, and nowadays it would be a lot less than that, it makes you reflect how the survivals change. And they were younger, fitter patients than the ones we do now. But anyway, that's an aside. For the 10-year follow-up of our patients in Middlesbrough, and this was before the widespread use of statins and beta blockers and ACE inhibitors, the survival is remarkably good and compares really well to the general population. And at 10 years, the quality of life was independent of whether they had bilateral mammary grafts or not. So that it was 90% their quality of life compared to the general population. And of those 1,100 patients, only 2% had PCI in that 10 years, and only 0.3% had redo coronary bypass grafts. And in our practice and our experience, we're not doing redo grafts anymore, but what we see is patients who develop aortic stenosis or mitral regurg, and they do the angiogram, and there are your grafts looking beautifully and patent, and you spend your redo operation tiptoeing around these grafts, trying not to touch them. And that gives us confidence that the mammary plus 2 is a safe option with good outcomes. Just check my notes here, excuse me. What's changed since that period of the 90s is that the patients we're operating on are very different now. For a start, PCI is taking out all the straightforward cases, taking out most of the non-diabetics. And therefore, as a cardiac surgical community, we are now getting the older, the frailer, the larger, the diabetic patients. And those are the sort of patients that aren't as sure to get a good result from bilateral mammary grafting. I think we'll hear from Bala some really good evidence why bilateral mammary artery grafting is good and why the patency is good. And I think it is a really good option for some patients. But the debate is, what is the target? What is the ideal strategy? What's the default strategy for coronary bypass grafts? And I think the default, despite its age, is still mammary plus 2. But every patient should be aware of the choices, of the risks, the benefits, and there'll be some patients that benefit from arterial grafting and go to the appropriate surgeon and unit. But I'll put it to you that the default and in effect the gold standard is mammary plus 2. Thank you very much.